Okay, so today my husband's going to serve as our guinea pig. So we're going to look at some patellar mobilizations. So if we're looking at patellofemoral pain syndrome, one of the things we're going to be assessing is quadricep tendon mobility and patellar tendon mobility. So we want to assess medial, lateral, superior, and inferior mobility. And a healthy knee joint, which you should find, is the 4 quadrants. You can see the lines I have drawn for his patellar borders: superior, inferior, medial, and lateral. In a healthy knee joint, these borders, the motion should be the same in each plane. So we'll assess here. He does have some knee issues, but they're on the other side, so we're going to try here. So we're going to do medial first and lateral. So if you can see, we have quite a bit more mobility medially than we do laterally. So we're probably having some VMO tightness through here. And then when we look at superior, that is all skin. So when you do patellar mobility, you don't want to just move the skin. Grab the patella itself. If you've never done this before, easiest way to do it is to make an L. Put it at the base of the patella on the inferior border. Now don't push down towards the table, especially in patients with chondromalacia. That's going to cause pain. Our cat Buster is coming to visit. So then we're going to go superior. And you can see there's no motion. This is just skin. Can you hold Buster? Come on, Buster.
Just taking to close the door.
All right, put Buster out in the hall. Now let's look at inferior mobilization as well. Same thing, if you're not familiar with the technique, easiest way to do it is an L. Put the L down. Now we're going to assess mobility in the inferior direction towards the distal tibiofibular joint. So we would say that his quadricep and patella tendons are both very tight. So if we were to do a quadricep stretch with him in prone or standing, he's going to be limited by quadricep tendon and patella tendon. They're both tight because we have very limited superior and inferior mobility here. So how we would treat that is same technique. Make an L, put the hand down. We're going to mobilize the patella itself, not just the skin, superiorly. You okay? Any pain? We're just going to hold, give it a little 5-second hold. And I usually do this about 10 times in the superior direction. Then I will switch my hand grips and do it 10 times in the inferior direction, 5 to 10 seconds based on the patient's tolerance. Now, if we were going to mobilize medial and lateral, this one is easier to do with just 2 fingers. So I feel he has more mobility medial, so I would do a lateral mobilization. So my goal is to mobilize in a straight plane. I don't want to push the patella down into the leg, to the femur and the tibia. That's going to be painful. So you 1 finger, medial aspect of the patella. You're going to pull towards the lateral surface of the body or towards the fibular head. Same thing. I'm going to hold, little 5-second hold. Any pain? And then relax. And that's how we would do patellar mobility assessment as well as how we would treat.